All right, I know some people are still logging in, but we are going to get started. It's after 5:30 now. So good evening, everyone. I hope everyone's doing well. I would like to welcome you and thank you for tuning into our webinar on lung cancer in recognition of November being Lung Cancer Awareness Month. I would like to thank our speakers who are with us tonight. We have pulmonologist, Dr. Jorge Mercado, medical oncologist, Dr. Joshua Sabari, and lung cancer patient, Eugene Dias. So thank you all for joining us tonight. And with that said, I am going to turn the program over to Dr. Mercado, who is with us in Grand Central Station right now. He found a quiet corner. Thank you, Dr. Mercado. I'm turning it over to you.
Thank you so much, everybody. I was planning to do this in a different place, but unfortunately, a series of circumstances got me in Grand Central Terminal in the middle of my commute, but I'm very happy to be able to talk to everybody here about a passion of mine, which is lung cancer, and specifically how in the last few years science has turned its corner, and we're finally tackling this problem, which is lung cancer. Many of you may know, many of you may don't know, but lung cancer is the #1 cause of death in the world among both men and women, deaths from cancer. And that is actually takes the #1 spot. It's an unfortunate #1 spot with the following cancers all combined in the next 3-4 cancers in the list. And all the numbers are staggering for lung cancer. So with that in mind, the reason why that are many. One of them that was something that we were always struggling, especially as my community of specialists, which is pulmonologists, was that we never had a really good screening tool for detecting lung cancer early. We always were basing our diagnosis in techniques that were mainly when patients came with symptoms, which is great for other types of diseases of the lungs, such as asthma, COPD, or such. But unfortunately, with lung cancer, when people have symptoms with lung cancer, it's unfortunately too late. That changed significantly when there was a papers published demonstrating, clinical trials demonstrating that a type of new technique called low dose CT scan, which is basically a CT scan that had less radiation in a certain type of population, made a difference and may discover nodules that may be suspicious. And that, when done properly under supervision of a lung cancer screening group, actually decreases the mortality in patients with lung cancer. And that makes sense when you think about you're discovering lung cancer early and you can do something about it. The other significant change that probably Dr. Sabari is gonna touch, I don't want to put an agenda to him, but there's been a tremendous amount of new medications able to treat previously cancers of the lung that were previously out of reach, and offering medications that were very, very toxic. So again, the prospect and the landscape for lung cancer from our perspective here at NYU Langone, Brooklyn, I'm very excited to be a team of physicians, nurses, social workers, and clinicians that are really tackling this problem head on. We have a nodule screening team, which Dr. Sabari and I are part of. Every week we discuss the nodules that our program detects, but we still have a lot to been present for a while, many years, but only less than 8% of the people that are eligible for these guidelines actually get the CAT scans. Having said that, the guidelines actually changed this year again to make room for more patients to be screened. Nowadays, you can get a CAT scan, low dose screening if you are older than 50 years of age, if you are a smoker or have smoked years.
Dr. Mercado, this is Rachel. You're breaking up a little
Yes.
bit. You're breaking up a little bit.
No.
I think wherever you move to, your service isn't so good.
Rachel, if you want me to jump in, I can.
How's that?
Okay.
Somebody?
No, you're stuck, Dr. Mercado.
Rachel?
I can hear you now, but your video is stuck. If you want, I can turn it over to Dr. Sabari and you can try joining again.
Can you hear me now?
You're still a little fuzzy.
Let's see. I can't hear you, Rachel, but let me see. I can see
That's
Josh. Can you tell me up and down if you can hear me with your video?
Yes. Yep, we can hear you now. We lost you again.
All right. I think Dr. Mercado is stuck. I'll jump in with my talk and then really have the pleasure of introducing Ms. Dai, Yujing Dai, who is going to speak more about sort of her personal relationship and her time as an advocate now with this disease. So can everyone see my slides?
Yes.
All right. So I'm going to be talking about medical oncology updates in non-small cell lung cancer. My name is Dr. Joshua Sabari. I'm a thoracic medical oncologist at NYU, and these are my disclosures. And the outline for the talk today is really building on what Dr. Mercado had talked about, thinking about lung cancer in the era of 2021. We'll then really move into the treatment paradigm, how we think about the treatment of lung cancer. And I want to focus on two clinical trials, really developing the next generation of targeted therapies in folks with non-small cell lung cancer. So who should be screened? And Dr. Mercado mentioned this already. You know, the age just changed. If you're 50 years old to 79 years old and you currently smoke or quit within the last 15 years, so at least a 30-pack year history, you should be screened with a low-dose CT scan of your chest annually. And we have a very robust program here at NYU. Here you can see my colleague, Dr. Shashua, on the bottom, talking to a patient about individual risk assessment for lung cancer screening. And this is the number if you're interested or have a family member. So true or false, only smokers get lung cancer? And the answer here clearly is false, right? So we need to do more. We need to do better. And I love this ad campaign from the Lung Cancer Alliance. So it doesn't matter who you are, what you do, anybody can develop lung cancer. So this is a beautiful campaign that says no one deserves to die. This concept of cat lovers deserve to die, the smug deserve to die, the tattooed deserve to die, hipsters deserve to die, crazy old aunts deserve to die, and the genetically privileged deserve to die. And we know, and we all come to work because of this mantra, every human is sacred and nobody deserves to die. So thinking about this concept is lung cancer really does not discriminate. One of my colleagues, Dr. Elaine Shum, a medical oncologist, thoracic medical oncologist, based off of this energy and this concept, has started a program, a clinical trial called the New York Female Asian Non-Smoker Screening Study. We've seen in our patient population that women of East Asian descent, whether born here in the US or outside the US, have a higher risk of development of lung cancer. So Rachel, let me have you mute your button if you can. Rachel, if you can mute. So Dr. Shum's study includes women who are between ages of 40 to 74. We're actually working on making this younger to allow all patients to enroll. This was the funding we were able to get for this trial, and it's never smoking status defined as exposure of less than 100 cigarettes per day. And what patients are offered is a baseline, a year 1 and a year 2 low dose CT scan in the radiology facility here. And actually these are available all across New York City, not only at NYU, but we've partnered with other centers, and we're hoping to really open this outside of NYU as well with a colleague and a collaborator in Boston. Patients are also getting blood-based assays to help detect cancer early. So this is 1 tube of blood where we're doing genetic testing to identify any alterations. People are also offered a questionnaire that looks at family history, environmental exposure, and World Trade Center exposure. And really, to plug Dr. Shum's project here, I highly recommend that you talk about this with your patients, with your family, with your friends. We've screened over 100 patients to date, and Dr. Shum has identified asymptomatic patients to have early stage lung cancers. And the best way to identify and to treat and cure patients is to identify these patients early so that they don't need any potential systemic therapy, hopefully, down the line. So I want to shift gears here into thinking about how do we treat non-small cell lung cancer in 2021. So we really think about the stage of the disease. And as I just mentioned, if we identify cancers early in the early stage setting, these cancers can be resected and patients can be cured without the need for further therapy. When cancers are diagnosed later on, like stage 3, where cancer started in the lung and learned to travel to lymph nodes in the middle part of the chest, we need to think about other potential treatment modalities like chemotherapy, for example, or even therapies after completing surgery. And lastly, in stage 4 disease, that means that the disease started in the lung and learned how to travel to other places of the body. We really need to think about systemic treatments or treatments that too can also go to other places of the body. So I want to focus really the rest of the talk on stage 4 or advanced stage disease, where we're really thinking about systemic treatments. And there are 3 forms of systemic treatments that we think about. The first being chemotherapy, and these are toxic or cytotoxic medications infused in the vein, and their goal is to kill cancer cells. Unfortunately, these medicines also kill normal cells, so can have some side effects like fatigue, potentially nausea, or lowering of the immune system. The second type of medicine that we use is immunotherapy, and immunotherapies, interestingly, do not kill cancer cells, but what they do is they rev up the immune system to better recognize and attack cancer. And these types of medicines have really been a major advance for patients with lung cancer in the last 5 years. And lastly, there are targeted therapies, and I always think about this as a lock and key. If somebody has a specific mutation or abnormality in their cancer, they may benefit from getting that key or that specific treatment that treats their cancer. And these medicines are available for multiple different types of alterations that we'll talk about. So going back only 5 or 6 years now, this is what we had available for people with stage 4 or advanced lung cancer. If you were diagnosed, your treatment option was chemotherapy based upon your histology or what type of lung cancer it was under the microscope. And if the chemotherapy did not work or stopped working or had too many side effects, we then talked about a second-line chemotherapy, which you can see here as docetaxel. And these medicines were effective and remain effective, but we needed to do more. And here's where we are in 2021. Biomarker testing has become critical. Biomarker testing is the concept of learning more about your cancer so that we can provide the best possible treatment. So first off, doing genetic testing on the tumor, on the cancer, to identify what mutations are there. Every cancer is caused by a potential mutation. Some are actionable, or we can act upon them with medication. So if your cancer has a mutation that is actionable, and you can see all the different mutations listed there above, EGFR, ALK, ROS1, BRAF, MET, REC, NTRK, we would highly recommend considering a targeted therapy. If your mutation is negative for one of these driver alterations or one of these mutations listed, we then look at something called PDL1 expression, or programmed death ligand 1, which is a cloak or a disguise on the cancer cell that predicts how likely immunotherapy will work. So how can we identify which treatments work best in individual patients? So the answer here is you need to do molecular testing. And if anyone's listening on the call that has a personal history of lung cancer or a family member with a history of lung cancer, a critical thing that you need to ask your health provider team is, what is my mutation? What's causing my cancer to tick? Because there are many approved now therapies available for you. That's based on the tissue itself, or the resection or the biopsy of tissue. We can now use liquid biopsy. So this is a blood test where we can actually assess genetic alterations in the plasma or the blood. And the reason why this is so important is it can tell us whether somebody has cancer cells or DNA in the plasma, in the blood, and we can actually act upon this. Based on this information, this can help us guide treatment. So this is an updated list of all the different alterations that are available or that exist with the medications that are available. And as we continue to sequence or do genetic testing on more and more patients, as we continue to do more and more clinical trials, newer and novel therapies are available for our patients. So I want to focus on 2 clinical trials ongoing here at NYU, specifically targeting 2 specific alterations. Before I go into that, I want to talk about how much effort and time, not only from patients and physicians and nurses, but how much time goes on in the laboratory, in the preclinical basic science realm, where thousands and thousands of compounds are tested, and many actually never meet the light of day. So it's really the scientists and the folks thinking about these questions. And one of the things I love about my job, and Eugene can tell you, is that what we do is we try to translate what we find in the clinic back to the laboratory, so then we can develop the next generation of treatments for our patients. So even before a medication on a trial ever sees a patient or a human, it really takes years and lots of efforts in order to allow that drug to move forward. Once drugs are then studied in the clinical trial realm, if safe and effective, they then move on to the FDA approved process. So I want to talk about 2 compounds that I've been fortunate in the last 3 years to see move through that process. And we've really led these trials here at NYU. So focusing first on the EGFR mutation. So this is a drug called JNJ372. It's now known as amivantamab. So this is a drug that was initially studied in 2017, 2018, and now in 2021 is FDA approved and available for our patients. So we know that there are many different mutations that can occur. EGFR is one of the more common mutations, occurring in about 20 to 25% of people. We have older generation inhibitors like erlotinib, gefitinib, that work well, but unfortunately, most patients develop resistance. And due to that resistance that people develop to these medications, we've then developed the next generation of inhibitors. And this is one of those next generation inhibitors that I want to talk about. So this is a patient of mine who I met now about 3.5 years ago, who came to me, 61-year-old male, who had a prior history of stage 4 squamous cell carcinoma of the lung. And he had these specific alterations or genetic abnormalities, and he had exhausted, unfortunately, all prior lines of approved therapy. So he had utilized all therapies in the pill form that were available for him. And here on the CT scans, you can see he was started on this drug, amivantamab, the EGFR antibody. And this is an adrenal lesion you can see with that pink arrow that measured about 6 centimeters by 4 centimeters initially, and reduced significantly to about 2 by 1 centimeter. So about a 68% reduction, over the course of the therapy. This patient remained on therapy and did very well for quite some time. So really, there's lots of excitement, lots of opportunities happening. So it's important, if you know your alteration, your physician can offer you potential other options that may not be FDA approved or available. And I'll end really with the other group of folks that I wanted to mention tonight. These are people with KRAS mutations. This is also relatively common, and this is a pie chart of all people diagnosed with lung cancer. You can see in orange, EGFR making up about 28%, but KRAS also a lion's share of the alterations, about 25% here. And historically, people who had these types of mutations were very difficult to target, meaning that we weren't able to develop drugs that bound specifically to KRAS. And it wasn't until about 3 years ago that these two drugs, sotorasib, which is now FDA approved, and adagrasib, which is really on the cusp of being approved, where we were able to see activity of these agents in our patients. So to date, we've treated 55 people with lung cancer here at NYU with these two KRAS G12C inhibitors, and there are many novel and newer therapies coming down the pike. This is my patient who was diagnosed with a lung cancer, who had growth, unfortunately, of the cancer after chemotherapy and immunotherapy, and was started on a KRAS G12C inhibitor, the medicine now here called sotorasib, or then known as AMG 510. And you can see the baseline scan. What you're looking at is the middle part of the patient's chest. In that X mark, you can see there's a mass measuring about 5.4 by 3.5 centimeters. And over a course of time, within about 6 months post the start of therapy, the patient has about a 50% regression. But more importantly, this patient was symptomatic when he started the treatment, and after starting therapy, no longer symptomatic. And this patient remains on therapy to date. So one common problem or one common issue with non-small cell lung cancer and targeted therapy in general is that people can develop acquired resistance. And what this means is that the cancer can outsmart the medication over time, and the medication could potentially stop working. So here you can see two examples of patients treated with different KRAS inhibitors. On the left, you see the tumor initially, they have a response, but over time develop resistance to their medication. And this is a paper looking at biopsies from patients who've had assessment of the cancer at the time of progression or growth. And we're able to identify different resistance mutations that then guide the next generation of drugs being developed. So this is data acquired in the clinic, in the office, that we're then able to bring back to our scientific colleagues in the laboratory to help develop new strategies. And these are some of the combination strategies that we're focusing on. I want to talk about one combination strategy before I end here. And this is a patient or really an animal model, a patient-derived animal model. So a tumor from a patient that was removed and implanted in a mouse model. And then we can test multiple different medications. And what you see here on the left panel is that the purple line, the vehicle, when this animal is treated with a control, so no medicine, the tumor grows out relatively quickly. The next two lines are in green and orange here. You see that when you combine or use these single agent drugs, the tumors grow slower, but then unfortunately grow out. When you combine a SHP2 inhibitor, which is an inhibitor that is up top or above RAS, and you combine that with a RAS inhibitor, you actually get more sustained regression of the cancer. And we actually entered this now into the clinic where we're studying the drug adagrasib in combination with a SHP2 inhibitor. And here you can see on your left-hand side baseline, initially up front before the start of treatment, you see multiple lung lesions. And then post 3 cycles, post 9 weeks of therapy, this patient remarkably has about a 60% regression of disease. So just a take-home point here, non-small cell lung cancer is not one disease. The therapy is really guided by lots of different things: the histology, the presence of any mutations, the cloak or disguise on the cancer cell, PD-L1 expression, and really talking to your physician, having a individualized plan is critically important. And it's also, it's key to have molecular profiling or biomarker testing, regardless of smoking history, regardless of you're a cat lover or not, right? Remember that it's critical in all patients. And then lastly, systemic therapy is active in non-small cell lung cancer, but we need to do more for our patients and for the folks in our clinic. So with that, I want to introduce one of my patients and somebody who I really respect and have a lot of admiration for, Yujing Dai, who has a BS from Rochester and a master in social work from Columbia. So she's an active practicing social worker. And I want you to hear her story, a young woman, a never smoker. And really, I'll give it to you, Eugene, to really take over.
Thank you, Dr. Sabari. So I'm going to tell my story. My name is Eugene. I'm a 32-year-old never smoker. I recently graduated from social work school and started a new job, but currently I'm on medical leave. So my husband and I just got married in May 2021. In August, I was diagnosed with stage 3A invasive mucinous lung adenocarcinoma. So today I will share with you about how I got diagnosed, the treatment that I have been going through, and some tips that I found useful for mitigating the side effects of chemotherapy. I was in my usual house until the end of 2020, where I had right facial palsy, then acute kidney infection by E. coli, which led to C. diff infection, and along come with a significant unintentional weight loss. Following an abdominal CT scan, my GI accidentally found a nodule in the lower lobe of my left lung. So due to the ongoing pandemic at the time, it was very difficult for me to schedule an early appointment with the pulmonologist at the time. So luckily, with a friend's suggestion, I was able to meet with my first medical oncologist, Dr. Guo, and a thoracic surgeon, Dr. Li, for further evaluations. Even after a chest CT and a PET scan, we still were not able to tell whether the nodule is cancerous. So in August, I had the surgery to remove the nodule and to have it tested during the operation. Unfortunately, it turned out to be adenocarcinoma, and I ended up with part of my left lower lobe removed. So then I was referred to Dr. Sabari, who is one of the most approachable, personal, and thoughtful doctors that I have met. He discussed and explained everything that we needed to know in detail, including the potential treatment plans and possible side effects of chemotherapy. At the time, Dr. Guo, Dr. Sabari, and my friend, social worker Yu were there to support my family and suggested that my husband and I could explore fertility preservation if we were ever considering having children in the future. So my husband and I decided to go through a fertility preservation procedure before chemo. The process of the fertility treatment took about 3 to 4 weeks to prepare me for an egg retrieval procedure before the end of September. At the end of September, I started my first round of chemotherapy. Then at the time, my genetic testing also came back positive for RAF fusion as the driver mutation. So we decided that we will continue with the targeted therapy after we complete the 4 cycles of chemo. So far, I have completed 3 cycles of chemo. And after the first round of infusion, I immediately experienced fatigue, muscle weakness, especially on my legs, and nausea, constipation, heartburn, and ear ringing. I was very tired and couldn't get up from the couch the first few days after the infusion. And I had no appetite most of the time. Even drinking water was very difficult. Luckily, a friend of mine, Allison, she's a physical therapist, and she's doing research on chemotherapy-related sensory motor dysfunction. So she told me that there are many studies suggesting that exercise can reduce chemotherapy-related side effects. So she suggested that I follow an exercise regimen, including at least 20 to 30 minutes of cardio, 5 days a week. and 2 to 3 days of appropriate strength training that covers all the major muscle groups. Since following her suggestions, I have noticed that I feel much less muscle weakness and fatigue after infusions, and I recover faster. For example, I remember that after my first infusion, it took about 10 days for me to completely feel normal again. Since I started the exercise regimen, after my second infusion, it took about 7 days, and the third only took about 5 days to recover. And my appetite also returned to normal in 3 days, and I had no ear ringing after the third infusion. Another habit that I found very helpful is to log everything I could every day, including the food that I eat, hours of sleep and exercises, bowel movements, and symptoms. Logging this information helps me to feel in control of my life again, and it also helps me to be mindful of my body and the lifestyle that I wanted to practice in the future. There are ups and downs, but I wanted to mention that having an understanding and supportive medical team, social groups, and friends around make things much easier for me during the treatment. I think taking one step at a time and focusing on the positives really keeps me going both mentally and physically at this time. Lastly, I would like to recommend a book that I read that helps me a lot during the treatment plan. It's called Moving Through Cancer by Dr. Catherine Shemis. The book covers topics about how exercise helps and with clear instructions for exercises before, during, and after different cancer treatments, as well as some inspirational stories. I hope you can share it with people that you know, and that's all my story for today.
Eugene, thank you. Really appreciate it. And when you told me about this book, I actually shared it with many patients since that time. It's hit or miss. A lot of patients say, you want me to exercise also while I'm getting the chemo, and I get some pushback. But from I would say at least half the patients, they're quite impressed and very thankful. So I really appreciate it. And I appreciate you and everything you do as who you are, but also as an advocate to those who come after you and before you.
Thank you.
Eugene, I agree with what Dr. Sabari said, and thank you so much for speaking tonight and sharing your story with other patients. And thank you also for the tips and the resources. I wanted to quickly share my screen. Eugene was kind enough to put together a little list for us. Let's see here. Eugene, can you see that on your end?
Yeah, I can see it.
Okay, hang on one second. Okay, so for anyone interested, here is the book that Eugene mentioned and also the exercise video. So I'm just going to leave this up for a moment in case you guys want to write it down. And Dr. Mercado, I see you're back. Did you want to add in anything?
No, yeah, thank you so much, Dr. Sabari, and thank you, Eugene, for such a compelling story. It's very brave to be able to share with everybody what you went through, and I'm sure everybody, we're all sharing, saying that we're very glad that you're doing well.
Thank you. It's my pleasure.
The one thing I technical problems didn't allow me to finish saying is that, as Dr. Sabari mentioned, we do have a program of lung cancer screening here at NYU in all locations, both Long Island, Manhattan, and Brooklyn. The lung cancer screening program is very important as you could tell that, as was told before, because trying to diagnose this early, we can make a difference. And one of the things that I wanted to mention is that now we also have the capabilities of going after these lung nodules at a much earlier stage. And the way that we do that is with a new capability of a robot that actually gets us to very, very small nodules anywhere in the lungs. And we're able to do that here in Brooklyn, but also in our locations in Long Island and Manhattan. So we have finished close to 50 cases, and we're very excited about the results because we're able to again, make a difference that way. With that in mind, I'll leave it up to Rachel for if there's any questions about the presentation.
Okay. Thank you, Dr. Mercado. All right, if anyone has any questions, please submit them in the Q&A box on the bottom of your screen. Give everybody a couple minutes.
So while people are asking questions, Eugene, I have one question for you. I mean, you're now, in my mind, a world expert in this disease. You've had, sort of consults at great institutions with fantastic doctors, not including myself at all. What would you wish you knew now that you knew that you didn't know when you got started? Like, what are some of the questions you would tell people to ask in the beginning?
I guess just like what is this, like the whole thing, like what's the genetic testing and how is that gonna help me? And what's the treatment plan? I mean, like when I started to know this diagnosis, I was very confused and I had no idea about like there is actually a genetic testing available. And all I know is like there's a cancer and I don't know how the chemo is gonna affect me, how effective it is, and what if the chemo doesn't work and what's next. I would like to ask those, at the beginning I wanted to know that, at least for the first part, like what is this cancer and how does this affect my life, and what should I do to prepare for, like to get cured or get treated. And like I said, like exercise, I would like to know that before I even start the treatment, because I think it definitely helps me the second round of chemo. And if I knew it before the first round, I'll probably suffer less from the side effect the first round, and just take one step at a time. And also social support or physical therapy, like recommendation, just for a quick evaluation of my body strengths before the treatment, just to make sure I'm okay and I feel like safe to do the exercises during the treatment time.
So Eugene, that's one thing I personally learned from you, is that exercise can be very powerful for patients during treatment, and also both physically, emotionally, but psychologically as well. So thank you, and that is something that I do talk to my patients about now. And one of the things I also think about a lot is stigma. And Dr. Mercado, maybe you can comment. There is a stigma around lung cancer, particularly with smoking, that causes this. But I think understanding that idea that look, people with lungs can develop lung cancer regardless of smoking or not. Dr. Mercado, talk to me a little bit about the stigma of lung cancer and how we break through. I think that's one of the limiting factors for us in successfully doing screening for our patients.
Absolutely, that's a great point, Dr. Sabari. To be honest with you, one of the major things that we have to fight in general, not only lung cancer, is a stigma with cancer. We had to go through this with colon cancer. We had to go through this with breast cancer, and I gotta admit, we have been making great strides on those types of cancer. There's almost like an overall sense of almost like unconsciousness that you need to check for those cancers, and everybody's aware of that. We need to make the same efforts for lung cancer. There's a great stigma with smoking, and we have to break that as well. And as you said before, not only people that smoke get lung cancer. There was a question actually on the Q&A that was asking about if there's an outreach being made to primary care physicians. I can tell you from Brooklyn, we were about to break through and go after a lot of primary care physicians in the community, and then COVID happened. Now that COVID, well, I want to speak too early, but now that we think that COVID is at least a little more controlled, we are going back and trying to reach out primary care physicians and try to make this lung cancer screening part of their annual physical exam when you ask if you actually qualify for a lung cancer screening CAT scan. We need to make this as the other types of screening techniques that we have for colon, for breast, and other diseases like diabetes, hypertension, and such. We have those tools now, and it's time to break the stigma that Dr. Sabari was talking about.
So just to give you some statistics, for breast cancer screening, we're at about 80% at NYU. So these are young, healthy women who get screening mammograms for their breast cancer. For colorectal cancer screening, so colonoscopy, it's a bit more invasive, we're at 60%. For lung cancer screening, unfortunately, in our area, we're only about 2 to 3%. So we have a long way to go. I think a lot of it is due to stigma, due to the recommendations being newer. But as Dr. Mercado mentioned, we are starting now to flag primary care physicians. There are notifications that pop up automatically in both patient charts as well as the physician charts for patients to talk about screening for lung cancer, right? The best way to cure something is to identify it early and essentially get rid of it.
Thank you. We have one question here. Are there any studies about ways of reducing side effects of targeted therapies in the long run?
That's a great question. So there are many different targeted therapies available now, over about 25 approved targeted therapies. Now, unfortunately, some of the older targeted therapies do have profound side effects. And, it has to do generally with inhibiting the wild type or normal gene. So for example, the older EGFR inhibitors have profound toxicity like rash and diarrhea because they block the normal EGFR gene, which is responsible for normal skin production and healing, as well as the lining of the gut. And now we have third generation EGFR inhibitors, which really have very little side effect or toxicity. So lots of work at the development of more safe and effective agents. For ALK rearrangement, ALK, some of the earlier agents that we thought about, things like crizotinib, for example, that were not very specific to ALK, had profound side effects. We now have newer agents like alectinib, which are more safer and have better activity. Unfortunately, at the time where alectinib stops working, the standard drug that we're using in practice is a medicine called lorlatinib. And the side effect profile from that agent is mostly CNS or central nervous system side effects due to inhibition of something called TRK or TRK. And lots of work now going on to try to minimize that. So one thing I commonly recommend is reducing the dose of the medication a little bit. Talking to your physician and seeing how to mitigate some of these side effects. So it's really in an individual basis, but lots of work happening in trying to make these therapies not only more efficacious, but just as important, more sort of tolerated or better tolerated so that people can have good quality of life.
Thank you, Dr. Sabari. There's a question here asking for more information about blood testing for lung cancer.
So, blood testing for cancer has become something that's commonly done in clinical practice. If you asked me this question 8-10 years ago, it would have been investigational where, we draw blood and send the blood test for genetic markers, just like we do for tissue. But now in 2021, I think all patients should have their tumor interrogated, so a biopsy, but as well should have plasma. It's controversial who benefits most. So people with stage 3 or stage 4 lung cancer should definitely get a liquid biopsy up front at the time of diagnosis. In patients with stage 1 and 2 cancer, it's more controversial because the yield or the identification rate of alterations in the blood may be a little bit lower. In clinical practice, we're using blood testing even as a surrogate or a biomarker on research protocols to understand whether treatments are working. Unfortunately, in 2021, we're still using CT scans, imaging, to understand the presence or absence of this genetic alteration or mutation. But I think in the near future, in the next year or two, we will be utilizing liquid biopsy to not only identify alterations, but then to manage and understand depth of response.
Yeah, we have been
Thank you,
started
Dr.
using.
Sabari.
Yeah, I wanted to add to Dr. Savari's great answer that we started using liquid biopsy or also blood samples to help us to make the diagnosis of whether there's a lung cancer or not. It's certainly not where we want it to be, but it's helping us to see if we can detect these auto antibodies and see if we can actually help us to tell us whether that nodule that we're looking at, if it's cancer or not. So we're starting that, and hopefully more in the future will be much more accurate. And again, we're in a very exciting time to with all the new discoveries and all the new tools that we have in order to again diagnose this early and managing this as at the least possible side effects available.
Thank you, Dr. Mercado. And it looks like that's all the questions for tonight. So with that said, I would like to thank Dr. Sabari, Dr. Mercado, Eugene, thank you for coming tonight and sharing your story with us. We truly appreciate it. And thank you to everyone for tuning in. We will see you next time.
Thank you so
Good
much,
night.
everybody.
Bye, everybody. Thank
Bye.
you.
Thank you.